Welcome for you, Dr. Hickey. We're glad to have you here.
Okay, thank you. Yes, hi everybody. So I'm Erin. I'm a med peds doctor at UIC, University of Illinois at Chicago. So I'm trained in pediatrics and adult care. I'm a primary care doctor for kids and adults with disabilities. I got into this field because my brother has Down syndrome and autism, and I saw how that transition to adulthood involves a lot and kind of is a period of great um, changes and a lot of support needed. And so that's where my focus has been. I have only practiced in Illinois, and I know this is a very diverse group, but I've tailored this presentation to more of a national look at transition and the kind of the major pieces of it. But please let me know throughout what questions you have and kind of how to tailor this a little bit more to your situations. I will say just for the question of conservatorship versus guardianship, to get that off the bat, it depends state by state. So typically we're using similar terms across states for conservatorship or guardianship. In Illinois, we use guardianship for people who aren't able to make their own decisions, but I'll talk a little bit more about that process in this presentation. So along with being a primary care doctor, I also run a transition consult service at UIC and come in and consult on patients 14 to 26 years old and talk about where they are at in this process and kind of what the next steps might be. And that's where I've gotten most of my experience. It is quite individual to the needs of the person, but I'm going to go over kind of the broad pieces. So I'm going to review the elements of healthcare transition, including how it relates to medical care, to education and waivers, finances. I'm only going to touch on very briefly because that was a much more in-depth talk about that relation, and then decision making. So first, just a quick introduction to transition. So healthcare transition is the purposeful and planned movements of adolescents and young adults with chronic physical and medical conditions from a child-centered to an adult-oriented healthcare system. At the most fundamental level, this often means the transfer from pediatrician to adult doctor, but as we'll go into, it really has many other elements and kind of social impacts than just that transfer to an adult doctor. This definition is from the American Academy of Pediatrics Clinical Report in 2011. They came out with a large report of most of the existing research, and then kind of needed research for this field, along with their adult counterparts, the ACP, and then family medicine. And they've updated that 3 or 4 times since then. They just came out with a new update in 2023 about the latest research, which kind of informs what the best practices are around transition. So this is how I picture transition. Again, a small part of this piece is healthcare. It's planning for once the person turns 18 to 22, finding adult providers when possible, kind of depending on the specialty, but typically, at least for primary care, finding an adult primary care doctor, making sure that they have adult insurance. And then I'll talk more about a portable health summary, which kind of takes in their most important features of their medical situation into a summary document. But it also involves their entire life, right? So from an education standpoint, what is happening after high school? How do we plan for that? From a financial standpoint, again, was much more in depth by Jeremy, but making those plans early. And then from a decision-making standpoint of who is going to be making the legal decisions from medical financial standpoint, how do we plan for that before they turn 18? So I'll go into each of these parts more in detail. The timeline, I think, again, this echoes a lot of what the previous speaker was saying, but it's starting early. And so these are the 6 steps of transition, which I'll go into more detail, but it comes out of a national resource called Got Transition. And starting early is the biggest piece of advice, but we can still make a lot of the planning later if we're already past this age range. But starting at 12 and 14 of just kind of introducing the idea of what does the support that the person needs look like now? What do we think it's going to look like in the future? And how are we making sure that we have those pieces together for the support they'll need once they go into adulthood? The initial steps are, this is kind of tailored for a pediatric practice for around 12 to 14 years old, for them to be telling the patient and the family, this is what transition looks like in our practice, and here's how we plan. But then really, as we get to like 16 and 18, having a very individualized plan for that person of what adult providers are we specifically looking for, what subspecialists do we need to make sure we have somebody on the adult side Do they accept what kind of insurance they'll have on the adult side? And what are they going to do after school ends? And then a big piece of this is really that it's not a break with the pediatric world, ideally. There's cross communication between pediatrics and adult after the transfer happens, so that you're still able to kind of follow up on anything that might have fallen through, changes that might have happened, and how to address those. So again, the major resource on this in the US is gottransition.org, which is a federally funded resource. They do a lot of the research on it, but then they also have provided resources, say, for your pediatrician to use and kind of help with planning. They have diagnosis-specific resources on what this might look like based on what medical condition the person has. And this is a large population. So transition is important for every human, like becoming an adult has pieces that everybody has to kind of adjust to. However, for people with special healthcare needs, which is about 18% of the population, there's more aspects to it that we need to plan for. And this is just to kind of say that this has been recognized as a needed resource in an important time nationally. So Got Transition, again, is the DHHS funded resource around transition nationally. All of the medical components, the adults, pediatrics, family practice have all put together joint statements on this and how important it is. And then the ACA recognized this as an essential part of health home service as well. So based on the research that we have so far, what happens if we do transition effectively? If we plan early, we kind of go through all of these stages and we have an effective transition. So planning this well shows that people have improvements in adherence to care, improved perceived health status and quality of life, improved adult visit attendance, and then a decreased time between the last pediatric visit and the initial adult visit. I'll say that the default is often not planning this out very well in advance. I can say from my own family with my brother James, but then also for most of my patients, a lot of times we hold on to the pediatric model as long as possible, understandably so, and then get to a point where it's kind of a quick transition to adulthood and kind of being pushed onto the other side once they've gotten into their 20s. For my brother, there was a long break between the last pediatric visit and the first adult visit, and it was due to a hospitalization, right? Which is quite often for people who have more medical needs. The thing that pushes them to the adult side is some quick change. And it's not always something that we've started quite early on and really has become this really planned process. So why does that happen? What are the barriers to making this an easy, smooth process? They've done a lot of surveys on patients, parents, and families' perspectives. And a lot of times there's difficulty leaving the pediatric provider. I can say that I see that personally. I work on the pediatric side. You're getting to know this provider for most of your child's life. You form a bond. You don't really want to leave them. And that's very, very understandable. There's also anxiety about going to the adult model. We really have a much more coordinated health model on the pediatric side. It's more often funded that way and possible on the pediatric side. And that is less often the reality on the adult side, which again makes this a difficult model to move into. And then there's a lack of adult providers who really are comfortable and trained to take care of people with more complex needs. This is something that we are focusing on really with research and support for training adult providers to be more comfortable taking care of people with pediatric onset complexity. But that's kind of the reality for families at this time. It's difficult to find somebody. Then from looking at it from the clinician perspective, there's often a lack of communication between the two sides. It's not often that you find an adult provider who speaks directly to your pediatrician. There may be barriers between the electronic medical records or what practices they are involved with. And so really trying to help that communication is an important thing to try to get over as far as a barrier. This picture on the right is from the Children's Hospital of Philadelphia's report on transition and kind of speaks to the other difficulty around this age, is that most of the resources that come in the pediatric model for people with disabilities or complex medical needs are built into the school and different funding that goes away in adulthood. There's a completely different model and support and resources on the adult side. And it's not as generous on the pediatric side. And so really trying to kind of plan to make sure that we're getting everything that does exist early is an important part of this transition. So going through each of these pieces, from a medical care perspective, I talked about the 6 core elements. And again, 1, 2, and 3 are really starting early and planning, talking about it with your pediatrician. If your child has a lot of different specialists, if they have a neurologist, if they see a developmental behavioral pediatrician, if they see a GI specialist, of seeing what that's going to look like for each subspecialty. I will say at UIC, we have a couple of pediatric neurologists who are like very specialized in taking care of that population, and they don't necessarily exist on the adult side, and they're willing to see people through the transition to adulthood. So it really is kind of subspecialty dependent. Typically for at least primary care, pediatricians, general pediatricians won't continue seeing a patient into their 20s, but it again is provider specific. So just getting an idea early of what your providers, what your subspecialist and primary care doctor see this looking like and what they're planning for. And then stages 4, 5, and 6 are kind of going into that transition of planning on who you're going to go see, making that transfer, and then making sure that it went well. And so I'll go over those in a little bit more detail. As far as the planning standpoint, I've talked about, I would definitely just talk to your pediatrician and pediatric subspecialists of who they know on the adult side. A lot of it, like I said, we don't have the same model of training for internal medicine and adult doctors, where they necessarily have as much experience with a specific diagnosis, but they will know people who are more understanding of disability in general, who have resources and will be able to kind of be a better medical home on the adult side. So getting that view from your pediatrician on who they might recommend. And then I mentioned the portable health summary. So this is typically like a 2-page document that has a list of the most important information about the patient, their diagnoses, who their subspecialists are, what medications they're on, their most recent labs and exam findings, so that when you go see the adult provider, they have a quick summary of what the most important things to know are. It's also really useful if you're going to an emergency room or seeing a new doctor or a provider for the first time, of just getting a quick glance of this is their baseline neuro exam, this is their what their typical seizures look like from their most recent neurology appointments, and this is why I'm presenting now, so that they can kind of get up to speed quickly on the baseline. So then step 5, this transfer of care, just kind of nailing down on these pieces, because again, ideally, it's not just a break from pediatrics. It's this continued conversation between the two, and making sure that your adult provider and your pediatric provider can kind of talk to each other to make sure that this is a little bit smoother, and that it went well, that you like them, that this is somebody that you want to stay with, or do we need to find somebody else? So the other part of the medical piece is insurance. And I know this was kind of talked on before, but if a pediatric patient is on Medicaid, once they are 18, they need to apply for adult Medicaid, or else they will get dropped from Medicaid. They need to apply for adult at 18. For some people who don't qualify for Medicaid in pediatrics, they will qualify in adulthood because it's based on their own assets typically. And also Medicaid is used to pay for waiver services for home and community-based services. So even if they are still on their parents' insurance or on private insurance, they may need Medicaid to pay for things like adult day services or respite care, and they may need that as a secondary insurance. Like you all know, that people can often stay in parents' insurance until 26, but with people who are dependent on their parents, it may be later than that, depending on the specific insurance plan. So I would just talk to your insurance provider. And then some people will be dual eligible for Medicare and Medicaid. That's on pretty specific situations. I typically need a social worker to help with those, but something else to keep in mind. So then from an education standpoint, so for everybody who has an individualized education plan, they also need to have transition planning integrated into that. Nationally, this has to start by law at 16, but it varies state by state. In Illinois, it has to start by 15 and a half. And this I really kind of harp on with my patients' parents, because again, most of the funding for resources come through the school. And so making sure that your IEP, your child's IEP, has a specific plan of what's going to happen after high school, how long they're going to stay in high school, and then what's the next step afterwards is important to discuss early and often. And if they are going to be working towards vocational planning or having a job, doing something afterwards, do they have built into their IEP the specific skills that they'll need to get into that vocational program? But if the plan is instead more like an adult day program or other community resources after high school, are they on the list? Usually there's a waiting list based on each state. In Illinois, it's called PUNS. Are they on that so that they know exactly where they're going to be going after high school ends? Each state also has individual laws on how long a student with a disability can stay in high school. Nationally, it's typically you can stay, if you have an IEP, you can stay in high school till you're 21. In Illinois, it's 22. Again, varies state by state. But like I mentioned, schools have the most resources. If a patient has an IEP, I usually recommend, depending on what the family's planning is, that they stay in high school as long as possible to get all of those resources. And then the waivers. So the home and community-based services waivers. This came out of when our nation kind of deinstitutionalized people with disabilities in the 70s, that the funding to take care of people with disabilities was put through a waiver system. They're all individualized based on state, but these are the kind of things that will pay for adult day programs, pay for home nursing, home services, and respite care. And so each person with intellectual disability has to register within their Department of Human Services division that supports people with IDD. And again, in Illinois, that's called the PUNS list, and getting on that list early so that they're able to get those waiver services when they need them. So these offices will help the individual apply for long-term support services through these home and community-based services waivers. And it's all just focused on keeping the person in the community as independent as possible to pay for things, like I mentioned, but also a personal assistant. So somebody that can help them with their activities of daily living if needed, and homemakers, home health aides, stuff like that. Typically, we need these waivers once they transition to adulthood, but there are waivers that apply to technology dependent children as well that will fund a lot of the resources that keep them at home. The wait list can be long and varies by state. In Illinois, we don't have one of the best ones. Our wait list is like 6 or 7 years. So I usually recommend that my parents get on the PUNS list at 14, so that once we're reaching the age of 22, they're higher up on the waiting list. And another resource is each state has an aging and disability resource center, which kind of goes through community resources based on your state. So then finances, again, Jeremy did much more in depth. The only thing that I like to, again, make sure that my parents know about is that somebody who receives SSI as a child needs to apply for redetermination at 18, or else they'll lose the SSI. So once they're coming to 18, they need to make sure that they continue to get it under the adult standard and apply for redetermination. The other thing to know is that for a person with a disability who's younger than 18 may not qualify for SSI due to their family's income, but once they turn 18, they may then qualify. And so applying as an adult under, again, the fact that they meet the minimum requirements for having their own assets at that point. And then decision-making, so guardianship. And again, in other states, this would be called conservatorship. But once a person turns 18, they legally become their own guardian. If they cannot make decisions for themselves, then we need to be planning on who will be making those decisions. So if a person is not able to make any medical or financial decisions, then a guardian or conservator is the best option. It requires paperwork to be filled out typically by the parent or the caregiver who will become the guardian, but then also a report from the physician. This is what the report looks like in Illinois that I fill out saying the person does indeed need a guardian. It also asks me who I think should be the guardian, which I know is typically the parent, but I fill this out, the parent fills out their documentation, and then they get a court date and have to go in front of a judge with their child to get guardianship. And again, that preserves their right to legal and medical decision-making. There are people who have, moderate intellectual disability or mild, who are still able to voice preferences, voice values, and make some decisions. And so there are some alternatives to guardianship that are less restrictive. I'm actually going to start with the one on the bottom, supported decision-making. So this is a new law in many states. It just came out in Illinois in 2021 as a new law. And it's an alternative to guardianship that maintains some of that decision-making for the individual. And so they're able to fill out a document that says, for support with medical decision-making, with financial decision-making, I would like you to talk to my parents and talk to both of us, but take my voice into account and what I would like in the situation. And so again, it's less restrictive and it gives them some more voice in their autonomy. The other two options on here, kind of other options for power of attorney, the individual needs to be able to state who they want to make decisions for them. So they have to be competent in that decision making. But if they say, I need help with decisions and I want my parent to be the person who helps me, they just sign a form saying that they identify that person. And then that for healthcare will be their, it's kind of similar in supported decision making. They'll help them when they need it. But healthcare surrogate is the default. So I can say for my brother James, we have been dragging our feet on guardianship for sure. It takes a lot of paperwork and can be kind of a process. And so we are really practicing under the healthcare surrogate law, which is, it's quite obvious that James can't make, he has a severe intellectual disability, he can't make decisions for himself. And so the default in each state goes to the surrogate. In Illinois, our Illinois surrogate law is that goes to your spouse, then your adult children, then your parents. And so for James, he is surrogate decision-making by law is our parents. And we've been using that to be his decision maker until we get guardianship underway. But really the best case in that scenario is that you get guardianship when they turn 18 so that you're not stating under the surrogate law. And that again depends state by state and can be a bigger deal if somebody gets married and maybe there's a difference in opinions between the spouse and the parents, and really kind of figuring that out earlier is important. But that is my broad overview of transition. Do you guys have any questions? Yeah.
We're from Canada.
Canada.
International access to is that Illinois based? That's great.
Yeah, no, great question. On portable health summaries. So I would go to gottransition.org. So they have examples of portable health summaries, and it's just a PDF that you can fill in. Yes, so many examples online. The one that I put up is from our Division of Specialized Care for Children in Illinois, but it really doesn't, the formatting is all the same, but it has the most important details of information on there.
And the other, and really difficult. Around that.
Yes. So do you mean for kind of this adult services to have a psychological assessment to say that he qualifies for them? Yeah, that is. Yes. Yes. So in the US that, and I think this, it sounds like it applies in Canada as well. For some of the waiver services, they need documentation of their intellectual disability. And it kind of depends on which waiver of when that needs to be done. For most of my patients, if we're applying for adult waivers, they can use their IEP from school saying the last assessment of their IQ is appropriate documentation for them to get those waiver services. But if they need a new assessment of psychological IQ and just overall assessment, it's very hard to get on the adult side. A little bit easier in peds. We can usually go through our developmental pediatrics, developmental behavioral pediatrics to get an assessment, or through neuropsych and pediatrics. And so I would, usually those two references will get it on the pediatric side. On the adult side, I usually talk to my developmental behavioral pediatrician friends on how to get it on the adult side, because again, most of the neuropsych assessments on the adult side are looking more for ADHD or dementia and not as tailored towards IQs in pediatrics.
That's standardized being able to find words still the communication by that pretty good.
So is this for tell me again what the assessment is for. Is it for uh-huh.
But they only use
Yeah.
You know, like the team, like, you know, family,
Hmm.
Very, you guys great ideas. Different way of looking at it.
Yes, yeah. And for some of that, this is more for on the adult side of qualifying for SSI and needing an assessment for that. We'll usually go through more of like physical therapy and occupational therapy to get that specific fine motor or kind of physical ability testing that they want for that. So I guess therapies might be another group that could help with the assessments. Yeah, yeah. Mm-hmm. Mm-hmm.
For the ability to be inactive.
Mm-hmm.
Around, you know, boards that we see set up within the high schools, obviously, but sort of outside of the. Bigger. I don't know if it's transition plan or these kinds of guardianship arrangements. Become the Kaiser.
And mostly around kind of access to our medical records, which yeah, yeah. Hmm. Yeah, so for access to our medical records, less than 18, there is like the proxy for the typically the app or my chart, whatever they'll use to get her records, that they'll take it away at 14. Within our healthcare system, I think most, if the person has an intellectual disability, they will keep that access to the parents. That's just for protection of teens and kind of their sexual and mental health. But after 18, the thing that will keep your access is guardianship. That's the most universally accepted. It'll be kind of hospital system based on per hospital system of and state by state on kind of the surrogate and access around that and how easy it is. Guardianship will make it definitely the smoothest. Or I think it is conservatorship in California. Yeah.
Just curiosity, if you don't have it and your child is above 18, what happens with tricky decisions?
Yeah, and so if for somebody who doesn't have guardianship over the age of 18, if they it's the doctor's requirement to assess capacity in each situation. So if you're going to the hospital, they need medical care. If the child or the patient can't voice and communicate what they would like done, then it goes to their surrogate. So that's why in a lot of cases with people with severe intellectual disability, it still defaults to the parents. But yeah, it does make it less smooth. Yeah.
And clearly we need to get it done.
Yes.
Now, I think we'll let this wrap up and give a big thank you.
Yeah.
to Dr.